I come to these meetings pretty upbeat because I do enjoy them, and it is one of the few times when we as clinicians sit down and talk to patients and hear what patients want to tell us. I think Ken Chapman's already outlined the issues about registries. They are absolutely critical. But there's an upside to registries, and there's a downside to registries. So I'll start by giving you the downside, and then we can get on with the good bits. So the downside is that in the UK, we've had a registry now since 1996, a web-based registry. And we've recently set up a hub-and-spoke system to use other departments around the country to see the patients who find it more difficult to travel to Birmingham with the same registry. I've now been called before our legal department to ask why on earth our own IT department didn't design the registry, or we didn't have one. And also, we haven't got the right word processor to design our registry. Point one. Point two is, well, what about confidentiality? How am I going to give these registries to other people and they won't find patients? Now, I think these are important issues. I think it is very important that confidentiality is retained. But when you've been running a registry for nearly 20 years, and all of a sudden, out of the blue, you get called to the legal department to now defend the fact that you've changed your registry, we've got problems. And I think the AIR, which I would call a registry of registries, should have had this problem also 20 years ago when we actually started to pull together registries from different countries using the same constant database to collect the same sort of information. But AIR has been very important, as have all these registries, in moving this field forward. And unless we can overcome this sort of minutiae of what really a registry is and how we continue to run it, I think we're actually going to be in trouble. So there's the AIR logo. We have had a bit of support, because getting support for these meetings, particularly international ones, is tricky. We've had a little bit of support from Baxter, we've had some from Octapharma, we've had some from Kamada, but our main funder really always was Bayer Biologicals, and then it became Talecris, and until recently it changed, they were providing quite a bit of infrastructure support to allow us to have meetings. So this is the overall registry. So this is the accumulation now of patients since we first started in 1997. I remember those first meetings because we all argued about what we were or weren't going to collect, and I thought we would never talk to each other again. And in the end, it became incredibly friendly, and we were all as one. So we all knew we wanted to collect the same sort of information. So I'm presuming that's going to be the point. Yes, so here it is, starting back in 1997. And this is the accumulation, and it was last monitored in 2014 with 5,215 patients on there. And that's predominantly patients who are PIZZ, a few PI nulls, and a lot of PI SZs, which I'll show you in a minute. So these are the countries which were contributing, so some very active countries, some not so active countries. And I hope what Charlie Strange is going to do in a minute is to talk to you about now bringing the same sort of concept and database into the US, so we can bring the US as well into this overall family of registries. Having set a registry up, you've got one moment in time, and of course at the beginning that's what we had a moment in time. Now for registries to be important, you need a moment in time, but you need to see what happens next. And so follow-up has become, from our point of view, quite a difficult issue, because again, you need some funding and some person's time to collate the data and submit it to a central registry. So this is now the accumulation of people where we've actually got follow-up data, sufficient quality for us to start to analyze. And we're only up to 3,000, so we've still got 2,000 more patients where we really need to get some sort of update. So just a little bit about it. I think the reassuring thing from the registry of registries is the consistency. There was always concern that, if you had ZZ in America, or you had ZZ in Norway, or you had ZZ in the UK or Germany, that the data you would see will be very different. And it may be that there are going to be some subtle differences, but by and large, it's pretty consistent. And that's important for us to know in this disease. So you can see the majority of our patients there are ZZ, so it's nearly 4,400, and over 600 patients with the SZ phenotype. I think with all registries, and looking even at just usual COPD, there seems to be a male predominance, and that may be related to previous smoking history, though of course a lot of the patients in these registries are never smokers or ex-smokers, so whether they're ZZ or SZ or even the rare variants, there still is a slight dominance of males in the registry. Again, consistently across countries and consistently across the world, it seems that the age of onset of symptoms in these individuals is pretty consistent. It comes on predominantly sort of around about the, the mid-30s to late 30s. That's the onset of symptoms. And then just like everywhere else, when you actually start to say, well, you know, when do people get diagnosed? It's some 10 years later after the onset of those symptoms, and when do the patients actually get first assessed properly? It's a little bit later too. So again, all consistently following this time course of a long period of time before someone actually gets really sorted out with alpha-1 antitrypsin deficiency. The majority of our patients are, of course, those with lung disease, because this was initially set up by doctors who were interested in pulmonology. And we've been struggling to actually try and update our liver groups. I think the reason we've got data on liver patients is because the liver doctors then, having made the diagnosis, send them along to the pulmonologist and say, are their lungs okay? And so we're sort of picking it up a little bit secondhand rather than having it as a very formal part of full assessment of all of our patients with alpha-1 antitrypsin deficiency. You can see there's a small amount of data there that is missing where we don't have data. We started up a pediatric registry that was led by Dino Hadzig, and Poland's been very active in this, but trying to get across Europe, the pediatric hepatologists to get their act together and to start to log patients into a registry has been particularly difficult. And I think this is going to become more and more important as we start to generate treatments and methodologies that we are going to use to try and protect the liver in children as well as, of course, in adults. So I was asked to say, well, what did I think the contribution of AIR really is? And I think the first and most important contribution of AIR has been that we've got people across the world who've basically had the same sort of interest talking to each other and starting to think the same way. And this has led to really quite a lot of contribution and collaboration. So we've had 3 big European collaborative grants, and getting those European collaborative grants, particularly in a rare disease, can be enormously difficult because, of course, everybody in medicine is looking for the same sort of grants. Occasionally you do get a specific grant just for rare diseases, and I don't know if Jan Stolk's gone now, but Jan was very instrumental in enabling us to understand the politics of the European Union in such a way that we could write a grant that had all the right words in it and tick the right boxes so that they would give us the funding, whatever the study was like. And sometimes people get funded because of the right words, not the right question. So we've been very successful along those lines with the European collaborative grants. We've clearly had a database there, and a lot of the countries that we've been dealing with have got patients who are not on augmentation therapy. And one advantage of a database is that when a company comes along to you and says, we would like to do a clinical trial, and these are the inclusion and exclusion criteria, what's happened in the past is people have said, oh, I've got those patients, and they bring them along, and then they say, oh, actually, they can't come into it because they're excluded, and they can't come into it because they're excluded. By having a complex database, you just press the buttons, and then you already pick up all of the patients who fit the inclusion-exclusion criteria. So it's much easier to recruit patients along to clinical studies. So the inhaled Kamada study, which we've now finished, and we're just coming to the final bit of analysis of that data, which I think is going to tell us a lot about alpha-1 antitrypsin that we thought we knew, but now we know we didn't know. I think that the first properly designed, I use the term tentatively, properly designed IV study was the Exactly trial, which was sponsored by Talecris, Bayer Biologicals, and Talecris, that was delivered predominantly by 3 countries. And that was Sweden, Denmark, and the UK. And we recruited very quickly to this and collected a lot of very, very carefully controlled data for it. There have been other members. It was difficult in the UK because there was still a placebo arm, so we couldn't get ethics to be involved in the rapid CSL trial. But again, a lot of that was done throughout the world, and Europe and members of AIR contributed very dramatically to that. There was another rapid trial, and I don't know whether we never called it Rapid 1 or Rapid 2, but the other rapid trial was this alveolar regrowth concept of using an RAR gamma receptor, which is something which actually develops alveoli, works in experimental animals. We did the study with Roche. There was bits of it that looked as though it was pretty promising, but Roche was so disappointed that the overall result wasn't devastating, and they had the same problem in usual COPD, that the drug was dropped. CT methodology, which now is very, very critical, was developed by people within AIR. And so Jan Stolk and Berend Stoll and David Parr in our group did an awful lot of validation work on CT methodology. And there's an updated report now, which I don't know whether Jan showed it, but showing that the lung function decline actually really does track with CT densitometry decline. So that's currently in press. Panniculitis is something that's lost to a lot of doctors who are interested in alpha-1 antitrypsin deficiency, but a very significant condition. And anecdotally, it looks very, very good in terms of response, but we are currently negotiating how to design a proper trial of alpha-1 antitrypsin deficiency, of alpha-1 antitrypsin augmentation in a panniculitis trial. And then actually from the database, there are a couple of papers which are underway. Again, you know, it is a question of very busy people trying to put together all the data from big collaborative registries to actually then make some sense out of it. But those papers are underway, so we've got a couple of descriptive papers and one paper which is in press. And because we've got such a big group of SZs, I think we're going to have the best data internationally then to look at what the SZ phenotype means. So finally, this is my last slide. So what are the opportunities that we see from large databases? Well, a large database gives you now the opportunity to follow up people across countries with and without augmentation in probably a much more structured way than Ken had to go about it, because he was just trying to find out what was in the literature, not what was necessarily in databases. It gives us an opportunity to look at rare phenotypes. I mean, if polymerization is so important and is the key lead for the ZZ deficiency, then, of course, people who've got the null deficiency won't have polymers. And yet the ones with the null deficiency actually do worse than people with the ZZ deficiency. So it makes us question just how much polymers are really doing for this. But again, newer therapies are coming along. There are oral agents and other ways of approaching this disease now where I think still there are sufficient patients within registries that are not on augmentation, which will allow us to do the initial pilot studies. And I think then in the longer term, we're going to be doing comparative studies between treatments that we know work and new treatments that we think are going to work as well. So I think that's it. Oh, yes, that's it. Thank you.